Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome back to the Gastro Girl podcast. I'm Jacqueline Gaulin, and today we're joined by the amazing Dr. Mitch Guttenplan, who is a general surgeon and medical director of the CRH O'Regan System. We have a very interesting topic today, something that you've been asking us about. We finally delved into this topic, hemorrhoids. I know it's not a sexy title, but it's an important one. Dr. Guttenplan, thank you so much for joining us today.
Thank you, and it's Mitch, please.
So let's just jump right in. You're going to help us understand what hemorrhoids are, why they happen, and talk about some effective treatment options that patients should know about, including the CRH O'Regan system, which is very interesting and why we want to bring it to the attention of our patients today. What exactly are hemorrhoids? Let's just start there.
Well, everybody's got hemorrhoids, and that's a misconception a lot of folks have. They're supposed to be there. They have a job. They're involved in continence, and there are these columns or cushions of a bunch of blood vessels and some connective tissue. And there's three main cushions. There's one on the left and there's two on the right. And they're held in place by these little muscle fibers that keep these cushions where they belong so they can do their job, which is what the tissue is very spongy. And if I'm going to try and strain and lift something, these things swell up. And it's one of the reasons why we don't mess our pants when we're really active. So they're supposed to be there. When we start talking about hemorrhoids, it's because of the symptoms that hemorrhoids cause. And the reason that hemorrhoids cause symptoms is because these muscle fibers that hold these cushions in place sort of give way over time. And then the cushions are able to start slipping and sliding. And it's the slipping and sliding or the prolapse that leads to the symptoms. And so when we start calling them hemorrhoids, it's really not the hemorrhoid's fault because they were there first. It's because they've lost their fixation and these things are able to slip and slide.
This is great info. So they're supposed to be there. And like you said, they're cushions and it kind of holds everything in. They have an important job in the body. But now we also often hear between internal and external hemorrhoids. Can you explain what the difference is?
Sure. So, and to be honest, there's a lot of confusion even among healthcare providers as far as that particular question. So most people would think, well, if it's an internal hemorrhoid, that means it's inside. And if it's an external hemorrhoid, it's outside. And that's really not accurate. The outside, I apologize in advance. I'm in a sling. I had my shoulder replaced. So I'm a one-armed surgeon right now. So if I'm motioning with only one hand, I do have another hand. It's just not available to me today.
Oh, so that's okay. Well, hope that there's no pain or anything.
Oh, that's why better living through chemistry. It all works fine out of the end. So what happens is the skin out here, when it gets near your bottom, it changes its name into what's called anoderm, and it's still skin functionally, and that extends up inside the anal canal a few centimeters. It varies from patient to patient. And that's where it joins or it meets up against the lining of the colon and the rectum. And that spot where the two meet, that's actually where internal turns into external. So there are actually external hemorrhoids inside the anal canal. Now, for practical purposes, everyone with external stuff has internal issues. Not everyone with internal issues has external issues. And so that's one of the reasons why there's also often a lot of confusion. Many to most patients that we'll be dealing with will have had or will need a colonoscopy. The colonoscope doesn't really do a great job of looking at the hemorrhoids. It does a great job of everything north of the hemorrhoids, everything upstream from the hemorrhoids. But because of, I won't get into the technical aspects of it, it misses a lot of the internal changes. And so oftentimes when people come to me saying, well, I don't have any internal hemorrhoids, they were missed colonoscopically. And we do what's called an anoscopy to get a look at things, and we can actually see what's going on. The external hemorrhoids are usually not symptomatic. The external hemorrhoids are usually the result of what's going on upstairs.
So there's changes to these vascular cushions, in other words.
Yes. Well, the internal stuff,
yeah.
there's lots of changes. When the muscle fibers give way, the tissue's able to flip and flop back and forth. The tissue gets beaten up, and that leads to the symptoms of itching and bleeding and swelling and prolapse and leakage. The externals are sometimes involved in symptoms, but more often than not, they're the result of what's going on rather than the cause of what's going on.
Okay, speaking of the cause, like what are some of the causes of this? What causes those changes and the flippy floppy thing that you just mentioned?
Basically, getting up in the morning enough times for a long enough period of time. There have been a lot of proposed things that increase the risk: sedentary lifestyles, chronic constipation, a lot of stressing and straining, a lot of people that have say desk-based jobs, long-haul truckers. I was in practice in Atlanta for many years, which is a Delta hub. We would see lots of Delta pilots. So all of these things play a role. But the bottom line in Western society, about 50% of us are going to have hemorrhoid symptoms at some point by the age of 50. And about 75% of people have hemorrhoid symptoms at some point during their lifetime. So there are things you can do to lessen the likelihood of these to happen, but you're not going to eliminate the risk completely.
Well, that's a great segue to our next question, which what are some of the common symptoms that patients should recognize?
The most common ones are itching, bleeding, swelling, prolapse, where stuff is coming out, has to be pushed back in, and some leakage issues. There are other issues that often accompany people with hemorrhoids, one of those being pain. To be honest, the pain is generally not the responsibility of the internal hemorrhoids. It's the responsibility of other issues that so many hemorrhoid patients have. In truth, the challenge that we face in treating people with problems with their backside, the hemorrhoids are usually not as much of an issue. It's the picking up on and treating the other stuff that so many hemorrhoid patients have.
Like, for instance?
The most common, people will have, if you looked at, we always have to write diagnoses down on after our patient encounters. And the most common secondary diagnoses for my hemorrhoid patient encounters were anal spasm, anal fissure, skin rash, constipation, diarrhea, all of these other things, a lot of functional issues. And you really have to address all of those in addition to the hemorrhoids if you really want to get everybody better.
Interesting. So how common are hemorrhoids and why don't people talk about them?
Tends to be embarrassing for many people. I'm a surgeon, and so part of my job is offending people, so I have no problem speaking about them. But lots of people are very bashful about that sort of thing. In addition, to be honest, there's a lot of horror stories that are out there about people that have sought care for their hemorrhoids. Some of the treatments that are out there are far less than pleasant, and oftentimes what I found in my practice, in my old practice, was that the patients that I saw, they've already told 2 or 3 or 4 providers along the way about these symptoms. And they've been told, no, you don't, the cure is worse than the problem. You don't want to mess with it. Just learn to live with it. Take lots of fiber, do these other things.
Oh, wow.
And so the patients are somewhat preconditioned to not ask anymore.
Oh, that's terrible. So they're suffering with this because it's not fun. I can't imagine when we talk. So are they pretty common? I know we kind of jumped ahead a little bit. So does it affect what is the percentage of people that may be affected by this?
Well, again, the literature will tell you that up to 75% of people will have issues at some point in their lifetime.
Yeah.
Internal hemorrhoidal issues tend to occur in patients. They don't tend to occur in patients younger than 20 years old.
Okay.
And the thought process is that those muscle fibers we talked about are generally still doing a pretty good job up until our 20s, and that's when they start giving up the ghost. The peak incidence of problems are somewhere between the 40s and the 60s.
Interesting.
But I've seen them in the early 20s, and I've seen them in approaching triple digits. So it runs the gamut.
Interesting. So you mentioned some briefly, but what are some of the main risk factors that are associated with the hemorrhoids acting up and things like that?
Well, again, it's a sedentary lifestyle. Obesity is one of those. Pregnancy is certainly one of those.
Yeah.
The classic story is we see many women who can tell you exactly how old their hemorrhoid issues are because it coincided with the delivery of a baby. But lack of fiber in the diet, spending too long on the commode. We used to tell people, I used to tell people all the time that the iPhone is one of the great causes of hemorrhoid issues in
Mhm.
modern days. And actually, in the last, I think it's been in the last year or so, there was actually a piece that came out that actually felt that there actually is a connection between cell phone use on the toilet and development of hemorrhoid symptoms.
Oh, that makes sense. So now this is an important question, and I love this question, is first steps for lifestyle and at-home relief. What lifestyle modifications can help? And you started mentioning fiber, which is it always comes up no matter what we're talking about in some level, whether it's constipation or something related to IBS. Fiber always comes up.
Yeah, and it seems as if you're going to do one thing, well, it's kind of one and a half things because fiber, and you got to take enough fluid for the fiber to work.
Yeah.
But if you're going to do one thing to try and limit the episodes and spread the episodes out as far as possible, add fiber to the diet. And in the West, we suggest somewhere between 15 and 20 grams of additional fiber. For the people that are out there, people love to take pills. And generally speaking, the fiber pills are worthless. The fiber pills, most of them have about a half a gram. So you have to take a whole fistful of these things to make a difference. I tell people you're probably better off eating the box that the fiber pills came in than eating the fiber pills to get enough fiber in there.
I thought
So you
people like to take those gummies. I don't know
you
many
can take
people
the
that like
gummies
to.
and they
Yeah.
work.
Okay.
They
But they
they
take
but
a
they
while.
can turn you into a bit of a musical instrument. The sweetener
Yeah.
will tend to well, you'll hear those complaints, and it's fine. If it doesn't affect you that way, that's great. Then there's the powders that are out there, and there are a bajillion of them. Um, of all the powders that are out there, the ones that I have heard the fewest complaints about are the wheat dextrin type powders, which includes Benefiber. That's the most popular trade name. And then there's a million generics that have the same stuff in there. But you got to take a lot of fiber. Take it with the meals. If you can divide the doses with the meals, it probably works better. Lots of fluid so the fiber works. Don't spend a lot of time on the toilet. And those are the best things you can do.
Yeah, that makes sense. What about over-the-counter options that are available?
They don't fix the problem. They can make the problem feel a little better. And there are a bunch of them that are out there. They have uh, um, all kinds of combinations of medications and all kinds of brand names. The one thing that I always caution against is the use of topical steroids. They are, in my mind, they are dramatically overutilized. And they sometimes can make the process more difficult to take care of than if you didn't use the steroids at all.
Now, because this is such a patient focus, I don't have a problem mentioning the names. Like people may not realize that some of the anti-itch things have steroids in them. Can you name some of the common ones that you've seen patients use? So just so that they're aware of what we're talking about.
Well, to be honest, almost every one of those that I've seen,
The itch
not
ones.
that I've done a thorough study through the hemorrhoid section of the CVS, they always do put a mention that there's steroid in there
Okay.
or hydrocortisone or
Yeah. Yeah.
some reference to that. And I would just avoid all of those things.
So it's the hydrocortisone, because that's what we see when we buy stuff in the grocery store or the drugstore. And that's what I wanted to bring, because we may not realize it's a steroid. So that's why I wanted to bring it up like that.
No,
Thank
that's
you.
right. That's right. Yeah, so I try to shy away from those unless there's an absolute indication to use them.
Great. And what about, we mentioned here, over-the-counter anesthetics and cleansers and antifungals?
So a lot of people that we see with hemorrhoid issues have a little yeast infection around their backside, and topical over-the-counter antifungals usually do a great job. Clotrimazole is one of the generics, but there's a million of them. And pro tip, if you go in the foot cream section, it's usually cheaper than if you go into the women's section to find these antifungals. So yeah, I promise you, you will not grow a toe down there if you use them.
Oh my goodness. We'll be having a whole new episode.
Yeah, that's right. But so that generally will help those. If people are having pain, there is a brand name that's called Recticare, and it's 5% lidocaine cream. And there are generics that have the same stuff, and that's a great numbing cream. It doesn't really fix anything. It just makes it feel better when it hurts. Usually when we're prescribing that, it's because the patient also has what's called an anal fissure, and they'll require additional treatment to get the fissure better, but the topical anesthetic will make it feel better in the meantime. A lot of times, particularly when people have an itchy bottom, they use a lot of baby wipes and diaper wipes and Tux pads. And in my mind, they're the worst because they keep the area wet and they remove a lot of the protective oils and whatever that's down there. So I tell people stop with the wipes. If you need a cleanser to get rid of that mucoid sort of discharge that some people with hemorrhoids have, there's another brand name over the counter called Balneol, Balneol. And it's a cleanser, and you put a little bit on a cotton swab or some toilet paper, and it'll help to remove that stuff. But we really want to keep the area clean and dry, and the wipes tend to do exactly the opposite.
Yeah,
So that's why I'm not a big fan.
that makes sense. What about baths?
Sitz baths are great symptomatically. It's likely not as much the water as it is the heat.
Mm-hmm.
And so some people will even use heating pads. There are two sphincter muscles that guard the house back here. And in many to most patients who are having hemorrhoid issues, one of those two sphincter muscles is too tight. And you get in a hot tub bath, and that heat will cause that sphincter to relax, which makes you feel better. So it's more of a soothing thing from the heat than it is the water. But that's fine too.
I love how you describe things, guard the house. I mean, this is great. You have such a way with words. It's great.
It's not garden back there. You got to do what you got to do.
But in all seriousness, when do these conservative options work and when do they fall short? And what do patients need to know? Like, it's time to look at something else.
Well, it's really up to the patient. You'll have two patients, and one will say, yeah, these things, they itch and they bleed once every couple of months. It's not a big deal. I don't want to do anything about it. And someone will come in and say, yeah, I'm having these things. They're bleeding and they're itching once every couple of months. They're driving me crazy. I want to get it done. So it really is a matter of what the patient wants to have done. You're not going to die from this. So it's a matter of when it's aggravating enough to you to get it addressed. We're happy to address it for you.
And that brings it to my next question, medical evaluation. When should a patient see a doctor and what signs should definitely not be ignored?
Well, anytime you have bleeding, you should at least check in with somebody. I think that prolonged pain is another thing that you should check in with someone. Everything that happens behind us, most people, and many providers say, they're hemorrhoids. Well, they can be other things too. And so if you're having anything that's persistent along those lines, you should go check it out. And the proper evaluation at a minimum would include a good physical exam that would include a digital rectal examination. And then based on the findings and the history, a determination can be made what's needed from that point forward.
Yeah, I want to stay here for a little bit because this is really important. We've talked to other physicians over the years of the importance of the digital rectal exam. And when a patient is having this recurring bleeding, the severe pain, swelling, what other things could this be an indication of? And I just want to really stay here and really help patients understand that you may think it's a hemorrhoid, but it could be something else. And we're not trying to scare people, but we want them to have a realistic understanding of what could be possibly going on there. What could this rectal bleeding also indicate?
Well, there are benign causes and there are malignant causes. Benign causes could include irritation, inflammation of the lower GI tract, so-called proctitis or colitis. Anal fissures can cause pain and bleeding. There's all kinds of skin lesions that people can have, many of them benign, some of them not. But then you can have polyps that can be precancerous, or you can have cancers as well. This goes from being the most benign of problems to the worst case I can think of was I had a 38-year-old woman who'd been treated for hemorrhoids for a year and a half, and clearly no one had done a rectal exam on her because when I did my exam, that was the largest rectal cancer I'd ever experienced in a patient. And it would have been very easy to pick up on if someone had just done a rectal exam on them. And nobody likes to have a rectal exam. And to be honest, nobody's thrilled about doing a rectal exam. But if it's indicated, it needs to be done. And if it needs to be done, it's a really important aspect of the patient-physician interaction that you're going to have. In my role with CRH, we help to teach people how to take care of hemorrhoids using the device that CRH makes. But I think the most valuable part of our interaction is we wind up spending an awful lot of time talking about proper evaluation as far as a digital exam and what's called an anoscopic exam.
Yeah, no, and I think that you're so spot on. And one of the things that we constantly try to help patients work through is that embarrassment factor. And I know the doctors do this day in and day out. Can we just talk a little bit about what, a patient, your recommendations, that it's not as embarrassing, they don't have to worry. The doctor's not judging them. Talk a little bit about that so they can relax and maybe feel a little more comfortable if they're sitting at home listening to this and thinking, oh my God, I think I have something going on back there, but I don't want to go to the doctor.
Well, I can't speak for all docs. I mean, we all do it different ways.
Right.
I use humor as much as I can with it. It's like they say, opinions are like backsides. Everyone's got one. And it's very, very common. It's generally speaking, the comments I get from the patients are like, how in the hell did you ever decide to do this for a living? And I checked the wrong box. That's my excuse. I can't speak for everybody else. But it's just, I think if you just, lighten the mood a little bit, patients are much more comfortable sharing this stuff with you. But, if I'm the patient and I got a problem and I'm going to the doc, hey, this is my problem. What do I need to do? And I would be, the patients have to advocate for themselves as well.
Yeah. So let's just briefly, I know we kind of touched on different points here and there, but what can patients expect during an office exam if they're worried they may have hemorrhoids? They may come thinking it's hemorrhoids, like that young woman. What can they expect during the office exam?
I think a lot of that has to do with what's happened to them previously as far as their history is concerned, and frankly, what specialty they're going to see. If you're going to see a primary care doc, my hope would be that the patient would be on their side and they'd be undressed from the waist down, and the provider would get a look at the outside, then hopefully do a digital exam on the inside. And then based on what they see, they would either then refer them most commonly to either a gastroenterologist or a surgeon. And when they see the gastroenterologist or surgeon, one of the things that we always tell patients is we want to get a look at what's going on right near the anal opening, but we're also going to want to be relatively comfortable that there's nothing going on upstream from there. And so if you come to me and say you're that same 38-year-old woman, and she's never really had any problems, say I didn't find anything really suspicious on the exam, but she was having some bleeding and some other issues. Okay, well, we're going to need to get a colonoscopy on you because we want to make sure, number one, that it is just hemorrhoids and you don't have anything north of there to worry about. And in addition to that, let's move it to someone who's even younger, that's 25. They're not going to have colon cancer, but they can have something called proctitis. They can have Crohn's disease. They can have these other diseases of the rectum that would actually make it dangerous for me to try and treat their hemorrhoids because the act of putting a rubber band on something, that area may not heal as it should and have problems. So not only do we want to rule out other problems that you might have a bigger fish to fry than your hemorrhoids, but number two, we want to make sure that the coast is clear and that we can safely treat the hemorrhoids if in fact that's what you've got.
Yeah, that's a great intro to the next section where we're going to talk about treatment options. So we're beyond the over-the-counter remedies to advanced care. What are some of the main non-surgical office treatments available to patients?
Well, all of them are basically trying to do basically the same thing.
Okay.
So going back to why hemorrhoids cause symptoms, it's because the hemorrhoids have lost their fixation. They've lost their muscle fibers that are holding them in place, and the tissue is able to slip and slide. So all of the non-surgical techniques are trying to basically get the cushion to scar back in place so it can't prolapse anymore. And there's a bunch of different ways to do that. People will try, and they all have their own risk factors. They all have their own pros and cons. The procedure that I perform is rubber band ligation. What's done is a little rubber band is placed around a part of the hemorrhoid. We're not removing a whole bunch of hemorrhoid. We're just getting a little bit of this hemorrhoid tissue to get it banded. It will die. It gets choked off, and it will slough off. And there'll be a little ulcer, a little sore that'll be left behind where that rubber band was. And that's sort of the tip of the iceberg. Up underneath the lining of where the hemorrhoid is, you have this irritation that goes on that leads to scarring. So it's sort of a spot weld to try and hold things in place. It seems of those techniques, and I'll run through them all in a minute, to be the most durable, the quickest, the cheapest, and the safest. There's another fairly popular technique called IRC, infrared coagulation, and it uses infrared light to try and cauterize some of the blood vessels. It's a really good stopgap technique, I think, but it doesn't give you the same long-term results. And my assumption is that the scar that's created is not deep enough to lead to the ultimate scarring that we require. And that's why I think if you look at IRC numbers, those patients need to be retreated a lot more frequently than other ones. There's a technique that uses direct current, where there's a little two-pronged device that's put up in an area of the hemorrhoid, and direct current is run across there. And that direct current, it doesn't create heat, but the direct current, it actually creates peroxide radicals at the negative electrode, and those peroxide radicals will help to fix that tissue to try and create the scarring. It works for the smaller hemorrhoids, but it takes a while. Larger hemorrhoids, you can have to hold this thing in place for up to 15 minutes, where the band ligation, for example, should take no more than a minute to do. There are other techniques that use heat. There's something called sclerotherapy, where chemicals are introduced, again, to try and create this scarring in order to get things to scar into place. The technique that's done most commonly in the West is band ligation, though.
And that's what you do with the CRH O'Regan system.
Yes.
And can you explain more about that? And, in full transparency, we're really excited to partner with you to produce this education for CRH O'Regan System, to produce this educational podcast. So we want to be fully transparent, but our mission is to bring patients the latest and greatest information so that they can make informed decisions in collaboration with their providers. So I'd like you to explain a little more about how the system works so that patients can better understand and talking with their providers.
Absolutely. So back in the day, and it's a long time ago, when dinosaurs still roamed the earth, I was taught to rubber band ligate hemorrhoids using conventional techniques. We would use a metallic anoscope, and we would put that in, and there's a little slot there. And through that slot, we would grab some of the hemorrhoid tissue and fire a rubber band over it. And it worked just fine. Problem was, there was a lot of pain, very often associated with the rubber banding. So the knock on rubber band ligation has always been post-banding pain. And if you look at some of the older techniques, up to 50% of people would have significant to severe pain. And in truth, back in the day, I would get frustrated. If I'm going to make someone miserable with a rubber band, I might as well cut the damn things out and do a hemorrhoidectomy, and then I won't have to worry about the banding as much. And so anything you could do to avoid the surgery is wonderful. What the CRH technique does, it allows us to put the rubber bands where we really want them. We talked earlier about the fact that the skin, the outside, meets the inside a few centimeters inside the anal canal. We need to be at least an inch, at least 2 to 3 centimeters north of there, so that we're clear of all the sensory stuff that we worry about. The CRH technique lets us get the band up there quicker, easier, and less traumatically. There's nothing magical about the rubber bands that the CRH technique uses. I tell people that the benefit of the CRH device is it's just a better widget to get the bands where they really need to get.
Oh, nice. That's really interesting. Now, how safe and effective is the CRH O'Regan system compared to other treatments?
So the largest collection of these cases was done by a fella up in Vancouver, British Columbia. And he had almost 99% success rates. Now, a lot of the success rates that you'll see has to do with your patient mix. Hemorrhoids come in different gradations and different levels of severity. And the more severe they are, the tougher they are to treat. So the garden variety hemorrhoid patient, we call them grade 2 patients. Those are patients with hemorrhoids that don't have to push them back in after a bowel movement.
Okay.
We tell gastroenterologists that you should see at least 90 to 95% success rates.
Wow.
And we tell surgeons that they should see at least a 95% success rate. And the difference there is every now and again, there is an external tag that a surgeon might want to excise that a gastroenterologist isn't going to. If you have a grade 3 hemorrhoid, and the definition of that is I have to push it back in after a bowel movement, they're tougher to treat. And so they may require additional banding, and the banding may not work. And so you're probably more like at an 80% success rate. As far as complications, if done as suggested, the complication rate should be roughly 1%. And the complications would include significant pain, significant bleeding, urinary symptoms. Some people get lightheaded. We call it a vasovagal response. And a very, 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 very rare risk of infection. And that's assuming we do 1 column of hemorrhoids per session using this technique.
Interesting. Now, is there much downtime for patients?
There shouldn't be.
Oh, wow.
There shouldn't be. A lot of patients that we see have also what we call an anal fissure, which is a tear. And oftentimes they're really uncomfortable and they really can't even tolerate the digital exam. Well, if that's the case, I'm not going to band it today because that would put them down.
Okay.
So what I would do in that circumstance is I would start treating that fissure and cool things off, bring them back in a couple of weeks. Hopefully they're doing better then, and then we can do it.
So
But the vast majority of people should be able to go back to work afterwards.
Yeah, such an important example of why that exam is so important, and not for patients to try to self-medicate and treat this on their own for long periods of time. There's other reasons, and you don't know what's going on down there until you see a doctor. So very interesting. Now, when, some people talk about hemorrhoid surgery, when are surgical options considered?
For different people will give you different answers to this. My answer is when everything else doesn't work. It's no fun. I had this very nice, this is many years ago, older guy. He came from Italy and he'd had the surgery, and he said he would, and I do a bad Italian impersonation, but he says, I tell people you don't have the surgery until they hang it down like a grapes. I would only have it done if it was the absolute worst scenario.
Okay.
Just because I know it's a miserable experience.
Now, for your system with the banding, the CRH O'Regan system, and I'm trying to visualize a hemorrhoid, and now you said the grape analogy, how big is too big for the banding?
It really isn't. Some people will require some additional banding in order to get it done. And some people that have large external components, they may need us to whittle on that external component in order to get everything better. But when fully instituting the treatment algorithms that we always preach and the ligator, roughly 99% of my patients were treated outside of the operating room. And that was my best part of all of this, because I always hated doing those surgeries.
Oh, wow. It makes sense. So what's the biggest myth about hemorrhoids you'd like to bust open today? No pun intended.
Yeah, I was going to say, using the word bust.
Oh, goodness.
Listen, I'll do the funny stuff, all right?
I'm not funny.
People think, and I understand, because there are some horror stories that are out there. It shouldn't be a big deal. The most common response, it's gonna sound like I made it up, but most common response after we fire the rubber band is they look over, because they're on their side. They look over and say, "That's it," and so it's not that big of a deal. And assuming that it's being used appropriately, like anything else. We tell people there's 2 mistakes you can make. You can band the wrong patient. There's reasons why you wouldn't want to band a specific patient, or you can band the right patient at the wrong time. And if you have a good patient, but they're too tender from something else, or there's something else going on, you back off and you just wait. You give it a couple weeks, and then you'll take off and do it then.
That's great advice. Now, you mentioned this briefly before, but I'm going to come back to it as we wrap this up. How can patients advocate for themselves? This is so critical.
Yeah. Well, a lot of it has to do with the scenario that they're in. It's funny. I now live in Utah. I practiced in Atlanta forever, and so coming here, I didn't know any of the docs here at all when I had to get my own health care. And I feel bad for lay people that don't have that kind of a background. But I think you need to get the answer that you need. Listen, I have a problem. Tell me what it is, or tell me what I need to do to find out about it, or tell me who I need to go to figure this out. And don't take no for an answer. There's always some other alternative. And if I always tell people that the first provider that I meet that is unwilling to say, I don't know, let me check that out for you, is one that I'm always suspicious of. I think if the answer to every question is I don't know, then you have a problem. But having an I don't know, let me check into that a little bit more, is something that always makes me feel better about whoever I'm dealing with.
Yeah. And one of the most critical things as we, patients trying to make decisions about their treatment plan is not knowing the options out there. That's why we were so excited to collaborate on this episode with you, because this is bringing another option for patients to discuss with their provider. Now, is the CRH O'Regan system available nationwide? Do patients have to ask for it? Can they find a provider somewhere on your website? Like, how does that work?
There is a physician finder thing on the website. We've worked with, I don't even know what the total number is now. It's over 3,000. I don't know if we had 4,000 yet, GIs around the country. So it's available. As far as I know, it's available in all states. I know from a training perspective, I've been to every state except for North Dakota and Vermont, and one of the other docs that does this has been to those states. So I think we're everywhere. And you just need to ask for it. And rubber band ligation is something that everyone should know about. And it's just a matter of what's the widget they're using in order to apply the rubber band.
So, doctor, one last question is, and all patients want to know, like, what's the prognosis? Like, are patients satisfied with the treatment? What's the result? What are you hearing in your practice?
Well, I haven't had a death threat in years, which is good. We always tell people that the best part of the interaction here is really the patient interaction, is even less so than the clinical interaction, because the patients are all thrilled about the whole deal. And I think a lot of it has to do with the fact that so many of these patients have been symptomatic for so long, and now, hey, we can take care of these problems. So the story that I always tell, it's a true story, is I was in practice at a trauma center for 20 some odd years, and I've never had a thank you note come back from my gunshot wound patients. My thank you notes all came from my hemorrhoid clinic. So we would get cakes and cookies and all sorts of things, and it was just awesome. Where the hemorrhoidectomy, not so happy. That's where the death threats would come from.
Oh God.
It's very much a less is more procedure. The patients get great symptomatic relief, which is the most important part. And we always tell the other providers that the patients are a hoot when they come in, that we will hear the funniest stuff that we've ever heard in a clinical interaction in our hemorrhoid clinics. The patients are awesome. So that really makes for a valuable, it's fun for the patients, I hope, and for the providers. The one thing we didn't mention that I should mention is that we're born with 3 hemorrhoids. We talked about this. And most of the time, not always, but most of the time, all 3 hemorrhoids need to be addressed. In order to keep things as safe as possible, we'll treat 1 column of hemorrhoids at a time. If you do more than 1 at a time, you can do more than 1 at a time, but the risk profile goes up significantly. So most people will require 3 treatments in order to fix everything, 1 for each hemorrhoid. In my practice, my old practice, the average number of bandings, I know the exact number, was 3.08 bandings per patient. So about 10 to 15% of people did not need all 3 banded. And we could usually identify them when we did our anoscopic exam. We could actually look at the hemorrhoids. And about 15% of people needed more than 3 bandings. The people that tended to need more than 3 bandings were folks that were, we call them grade 3s. They have to push them back in. They will often need more work. And some patients that are having leakage issues need more than 3. But that's how it usually falls out.
No, this is great information. I hope our patients really take this back to their providers if they're considering, we hopefully help them not be afraid to go talk to their doctor about something that maybe not feel right on their backside. I really appreciate you, Dr. Guttenplan. This has been so interesting. And remember, patients, hemorrhoids are common, they're treatable, and nothing to be ashamed of. The most important step you can take is to speak with your healthcare provider instead of suffering, as we always say, in silence alone. Safe, effective treatments, including the CRH O'Regan System, are available. Thank you again for helping us shed light on this important topic. For more trusted resources, visit gastrogirl.com or use the Ask Gastro Girl app to connect with evidence-based information and support. Don't forget to like, share, subscribe this episode and our channel on YouTube and all of our podcasting platforms. Thank you so much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.